So today we are going to discuss about ascites. So what is ascites? Ascites is actually abdominal swelling which is caused due to accumulation of fluid, mainly due to liver disease. As you can see in this picture, there is accumulation of fluid in the abdomen. There is swollen abdomen. This is ascites and it occurs mainly due to liver disease. So decompensation in cirrhosis means when decompensation happens, then portal hypertension will be there. And the earliest complication of portal hypertension is ascites. Means if portal hypertension is there, then the first complication that we are going to see in the patient is ascites. Okay, what is the pathophysiology? Means how that fluid will be accumulated. Now we are going to discuss that. As you can see in the picture, fluid is there in the peritoneal cavity. This is ascites. So what happens is, we know that if the patient has entered into decompensation stage of liver disease, then portal hypertension will be there. Now if portal hypertension is there, then it will lead to splanchnic vasodilation. Blood vessels will dilate. It will lead to defective intravascular volume, and so it is going to stimulate the RAS and the sympathetic system. They will get stimulated, and what will that result in? Sodium and water retention. Because of the action of RAS and sympathetic system, sodium and water will be retained. Now what they will lead to? The fluid will leak into the peritoneal cavity. It will start leaking into the peritoneal cavity via hepatic vein and sinusoids, and so fluid in the peritoneal cavity is what? It is ascites. Simple. So how are we going to diagnose ascites? So diagnosis is, you can go for ultrasound. Minimum 100 ml of ascites fluid can be detected by ultrasound. Then shifting dullness, 500 ml of ascitic fluid. Then fluid thrill, 1000 ml of ascitic fluid will be detected. Then ideal site for ascitic fluid tap. So where are you going to tap for ascitic fluid? It is in the left lower quadrant. Means if in the abdomen, if you go into the left lower quadrant, you have to tap. That is the ideal site. 3 cm cephalate and 2 cm medial to anterior superior iliac spine. You have to go 2 cm medial to the anterior superior iliac spine and 3 cm cephalate. There you should tap for ascitic fluid, where in the left lower quadrant of the abdomen. Then comes the management. So you know that in ascites what is there is sodium and water is there in the peritoneal cavity. So you have to ask the patient to reduce the salt intake. Salt restriction should be there, and you have to monitor the urine sodium. If sodium potassium ratio in urine is less than 1, then you can start with drug therapy. But if it is more than 1, then you have to ask the patient to go for further salt therapy. Means less intake of salt should be there. To reduce that fluid, you have to give diuretics to the patient, which includes spironolactone 100 mg plus furosemide 40 mg. If the patient is not responding to diuretics, then you can add medodrain drug. If he is still not responding, then you can go for therapeutic paracentesis. That means you will drain out that fluid manually every 2 weeks. And if still not responding, then you have to go for TIPS. TIPS is the last stage. What happens in TIPS? TIPS is actually transjugular intrahepatic portosystemic shunt. Shunting will be done at the later stages when it is not going to respond to drugs, paracentesis also. Then you will go for TIPS. This is the management of ascites. Then are complications. Means if ascites is there, then it can lead to spontaneous bacterial peritonitis. Means it will be infected, that fluid can get infected. It can lead to hepatorenal syndrome. It can also lead to malnutrition. Pleural effusion can be there if it leaks. If it affects the pleural cavity, then gastrointestinal bleeding can also be there. So this is all about ascites. Thank you.